Assalamu alaikum. I'm Dr. Mohammad Sadilyas and I'm an assistant professor with the Department of Orthopedics and Spine Surgery at Ghurki Trust Teaching Hospital, Lahore. So, today, obviously, ये third session है हमारा Orthocon में foot and ankle का, and we are discussing all sorts of things. हमने MIS भी discuss कर रहे हैं, fixations and everything. इस talk का एक aspect ये था कि जो हम आपको दिखाना चाह रहे थे कि जो चीज हमारे I think very few countries in the world are doing this, कि हमारे पास Ilizarov surgery भी बहुत frequently होती है. West doesn't have this, and we have this in our armamentarium, and we use Ilizarov to correct almost all sorts of deformities. So I think he needs no introduction. Professor Amir Aziz is my role model and my supervisor. And then Dr. Mark Myerson, I'm attached with him for past 4 years now, and he's my mentor in foot and ankle surgery. This is our team at Ghurki Hospital, Lahore. So why do we need Ilizarov in foot and ankle? The magnitude of deformities that we encounter, it's unparalleled. People in the West, in the developed part of the world, don't see these deformities. There are two reasons. One is the neglect. Most of the people don't approach a doctor for the treatment. The other problem is when they do approach someone, and if the doctor doesn't know, he says that go back and you come back to me when you're 18 and then we'll think about something. And by that time, the deformity is already severe. Or sometimes, and many a times, people operate the cases and make the deformities even more bizarre than they originally were. And no matter how skilled you are, whenever you're trying to correct a very severe deformity in an acute way, you will have soft tissue and skin problems, and you will have recurrence of the deformity. Here, Ilizarov comes into play, and you can have a deformity like this, and in an attempt to correct it, you can end up with soft tissue problems, and by the end, the foot can still be deformed, but in another plane. So for these cases, Ilizarov is a very good option to do the salvage, and you can apply Ilizarov and you can easily correct the deformity. So I'm going to give you a brief overview and show you a few cases that I've been doing. We can treat all sorts of ankle deformities with Ilizarov. I'm going to briefly show you cases like you can have a patient with a non-united tibia fracture with scarring all over and a deformity. So you can easily, one option is you can send the patient to a plastic surgeon, have him do a flap and then do reconstruction. The other option is you can apply an Ilizarov, don't give any incision, just correct the deformity and let the histogenesis do the work. Distraction histogenesis. So again, in this case, Ilizarov was applied, no incision was given, just the deformity was corrected. And in the process of gradual correction, the osteogenic process started and the healing occurred. You can see. You can have, this was a case of valgus deformity. You can have a varus deformity in an ankle. In a patient like this, obviously he's the patient of some sort of epiphyseal dysplasia with ballooning up of joints and a varus deformity. So it's the magnitude of deformity is about 40 degrees. So you cannot correct this deformity in an acute way. Or if you try to correct it, you will do a lot of shortening and there will be a chance of soft tissue problems. So you can easily correct these deformities if you know the principles of deformity correction. You can easily correct these deformities with an Ilizarov without having any soft tissue complications. You can have a procurvatum deformity of the ankle because of old injury or some physeal arrest. And again, a magnitude of 58 degrees. So you can plan it, apply Ilizarov through a very small incision. You can correct the deformity. So you can have foot problems. So in this patient, he's a 16-year-old boy with bilateral club feet. The right foot is, though the right foot looks more severe, but it's an untouched foot. This is the foot which the patient had since birth. The left foot deformity correction was attempted by someone. So these the foot which have been touched before, they're always bizarre. So deformity doesn't follow any pattern. But you can, no matter what the deformity, you can correct these with an Ilizarov system. Again, bilateral Ilizarov applied. Gradually, the deformity got corrected. No matter what the deformity, you can make the foot plantigrade. You can have a 36-year-old male who's 140 kgs of weight with severe club feet, and where X-ray is looking like this. Again, with an Ilizarov fixator, you can easily, no, not easily, you can correct the deformity. So these are the problems where the things get trickier, because before this, these are club feet, they follow a pattern. These are the feet in which these people have had multiple surgeries. So you'll have the ankle going in valgus and external rotation. You'll have the heel going in varus. Then there will be adduction deformity in the midfoot, and the toes will be going in the other direction. So you'll have skew feet because of the previous surgeries. So these patients, these feet do not follow any pattern. So the technique that I have devised is I do acute correction just to make a sense of the deformity, and the rest I correct gradually. Like you have this girl had hip dysplasia, and a surgeon tried to do lengthening of the leg. And because in an attempt to lengthen the leg, she ended up with a foot like this because of Volksmann ischemic contracture that developed. So in this patient, she had you can see the lengthening was attempted. So in this patient, I first did the midfoot osteotomy, corrected the excessive adductors and the cavus. And then for the ankle, I applied this fixator and then gradually corrected it. So by doing this, you can correct the deformity using an Ilizarov fixator. So you can have a foot like this. So we are the country in which we can even have people coming to you with feet looking like this. So this was the result of multiple plastic surgeries when the girl was 5 years of age and she had a run-over injury. And now she was 10, she was 15 years of age. Now she was walking with a foot looking like this. Obviously, you have to take the consent for the possibility of an amputation during the treatment. So, and tell the patient that whatever you do is experimental. This has not been done before, because so in this patient, there were multiple problems. One is the severe magnitude of the calcaneus deformity. The other problem was the skin of the dorsum of the foot it was not skin, it was scar, and it was tethered to the shin. So again, as a percutaneous osteotomy through a very small lateral corridor where the skin was intact, a percutaneous osteotomy was done, fixator was applied, and distraction was started. And as expected, the skin, the dorsal skin, the tether started to pull the toes. So in this patient, as you can see, what was done, I made a transverse in CN to just release the skin, fix the toes with the assembly, and gradually distract it. And my plan was that once the deformity is corrected, I'll just do a split thickness graft to cover the gap. But here, the distraction histogenesis took its part, and the skin started to heal on its own during the process of distraction. And by the time the foot was plantigrade, it was a very healthy scar covering the toe, covering the dorsum. And I was able to give her a plantigrade foot with a very healthy scar. These are the X-rays. And many a times, this is also again a result of multiple surgeries. Now, if you see a patient like this, there is always a tendency that this patient has a cavovarus foot. Just correct it. You need to have proper radiology. I cannot stress this enough. You need to have proper radiology. The problem is this patient has an external tibial torsion of about 40 degrees. And this happens in almost all of the cases of this severe deformity. And if you send your patient to a radiographer, he'll take a standard X-ray, which will be an oblique X-ray because it's external torsion, and you will be misguided. So again, in this patient, when I took, this is an X-ray, and I took the patient to the radiology, rotated the foot, and then when I get an ankle AP X-ray, I find out that the boy has at least 45 degrees of varus that is being contributed from the ankle. So again, in this patient had a varus deformity at the heel. He had a varus deformity at the ankle joint, and he had a cavus and adductus deformity at the midfoot. So again, I plan to correct part of it acutely and part of the deformity in a gradual way. This was my planning. I applied fixator to the tibia, to the ankle and the hind foot. Again, osteotomy was done. Varus was corrected from the ankle and at the heel level in the first stage in a gradual way. And when the hind foot and the ankle was corrected, then I did a midfoot osteotomy to correct the adductus and the varus and slightly derotated the foot as well. And the patient was allowed to fully weight bear. And after some time, I was able to achieve a stable plantigrade foot. So this is a girl with extreme degree of Aquinas deformity. And this is actually a pathology which I had never seen before. You can see here. Initially, I thought that it's a case of fibular hemimelia, but this girl had another foot attached to the leg when she was born. There was a separate ankle joint arising from the fibula, and there was another foot attached here, which some surgeon removed when she was very little. I tried, but I could not get the picture. So now she had an extreme degree of Aquinas deformity. The talus is obviously flat. She had a short leg. So again, I tried to correct the deformity using an Ilizarov fixator. First, I distracted the ankle so that I have enough room to just correct the deformity. Simultaneously, lengthening was done. And with this deformity, Aquinas was corrected, then osteotomy was done and limb was lengthened. She's going to need 2 more attempts at lengthening because she has a severe degree of, she has a lot of shortening there. Lengthening was done. And this was the end result. Now she is able to use his foot. So this is a brief overview of how we can use Ilizarov to salvage quite complex deformities which are otherwise goners. Thank you so much.
Thank you. So if there are a couple of questions, we can take them. For Dr. Saad Ilyas or Dr. Dilbagh on his Alex Felkus talk. Yes, Dr. Suhail.
Fascinating work. You asked a friend or colleague to come from abroad and talk about these cases, and I'm baffled, absolutely baffled. I have no clue how you sleep. And that's all I just want to say. Fantastic work.
Thank you, sir.